But I don't know if it's the same camera. Maybe it's different. Yeah, it's a silver one.
Can you get people to sit down? Good morning, everybody.
Good morning.
Good morning, everybody. I'm fired up. Say ready to go. I'm fired up.
Fired up.
I'm fired up. Ready to go. All right. Hey, you guys. Nice to know that we're all awake. Quick vital announcement. There is coffee and tea just out the door around the corner to the right. So if you to the left. Right over here. Right over there. Thanks, man. So if you feel the need to caffeinate, stand up, do what you need to do to stay focused. We're in the last stretch of this. Let's get started. So my name is Emily Henkels. I am the national organizer for PNHP out of Chicago, Illinois. And I want to thank Healthcare Now for letting PNHP do the plenary session this morning. It's called the ACA, Challenges and Opportunities for the Single Payer Movement. I'm going to quickly introduce the representatives from PNHP, just all in a row, and then I'll let them take it from there. First, we're going to hear an overview of the history of the Affordable Care Act from Dr. Jim Powers. Dr. Powers is an associate professor of medicine at Vanderbilt University School of Medicine, where he's the chief of geriatrics at the medical center. He's been an advocate for single payer since his third year in medical school. Dr. Art Sutherland, you guys met yesterday. He's going to discuss where the ACA falls short of universal coverage and flesh out a few examples of the differences between what we have now and true single payer. Dr. Sutherland has traveled all over the South advocating for single payer, and as you heard yesterday, is currently the state coordinator for PNHP Tennessee. Many of you know Dr. Derek Adams as the immediate past president of PNHP. He's a pediatrician specializing in infectious disease in Louisville, Kentucky. Since retiring from the University of Louisville School of Medicine, Dr. Adams has founded a comprehensive ambulatory clinic in the underserved community of Yeshua Springs, Tennessee. Dr. Adams has a strong connection to Nashville. Was born actually at Vanderbilt Hospital, and then also interned at Vanderbilt too. So I'm super happy to be here today. And he's going to be speaking on why and how we can organize around single payer now in the midst of the implementation of the ACA. If we have time afterwards, we're going to do a quick exercise about pooling our assets so that we can better organize together for single payer. But for now, let's dive right in, and I'll open the floor for Dr. Powers.
Thank you, Emily. I am not a policy wonk. However, I have learned a lot from policy wonks. And I'd like to take you on a journey that I have traveled to learn the place of the Affordable Care Act in history, and also looking beyond the Affordable Care Act. Emily, the first slide. Over the last 100 years, 6 U.S. presidents have tried, and the Obama administration succeeded in a major health care law passage. This was done largely as a result of Rahm Emanuel, his chief strategist. To railroad this legislation through Congress, he had to form a coalition. And I'd like to tell you a little bit about the elements of that coalition. As you see, single payer was really not an option. Consumers were to gain improved access and affordable coverage that was promised. The insurance industry would get many, many millions of new enrollees in return for new regulations, limiting pre-existing conditions in profit loss ratios. Pharma would have a huge market share in return for price controls and national purchasing pools. The hospitals would agree to reduce Medicare payments in return for less uninsured. Primary care physicians were going to get increased reimbursement, and employers would have subsidies for small companies. Well, let me tell you the setting of the healthcare landscape at that time. Emily? Poor production. This is a graph of where the U.S. falls in terms of comparative spending to other countries. We're here at the end, spending more than twice anybody else in terms of healthcare spending, yet being 37th in terms of many healthcare outcomes, infant mortality, longevity, access. Next slide. This is a page from the Dartmouth Atlas. Over the last 7 years, the Robert Wood Johnson Foundation has funded this project, and there are many thousands of pages in this atlas comparing all kinds of costs. These look like counties, but they're actually hospital referral areas. Some of them may be counties across the country. There's absolutely no correlation between healthcare spending per population, per condition, and quality or outcome. It does often correlate with the number of specialists, however.
Can you explain the colors? I don't know what they mean.
The colors are, just to show you the great variation, the darker colors are increased spending lower spending per beneficiary. And the lighter colors are higher spending areas. But what we have found, the Institute of Medicine is actually looking at this variation. It turns out that early results are that 3/4 of this variation are in post-acute care services. So look for a lot more information coming out about all of the things that we order after people leave the hospital. Next slide. As a geriatrician, I have to point this out to you. The U.S. population is aging and will be over 20% of the population and be at that level for at least the foreseeable 50 years to the future. And what does this mean with regard to Medicare and Medicaid spending? Emily? Here's a graph. The trustees of the Medicare funds and Social Security report to Congress periodically, and this is a 2012 report showing that by 2026, this is the red line here, the Medicare Trust Fund will go broke, and this is the Social Security Fund 2038. And this is based on projections. When these programs started, there were 10 to 12 U.S. workers per retiree, but we are living longer, 3 workers per retiree right now. So what happened was that the act passed through Congress very quickly. The Affordable Care Act was first proposed in October of 2009, and it passed in the House 410 to 0, no opposition at all. It then went to the Senate. Many of you might have stayed up all night watching this on Christmas Eve, and it passed 60 to 39. The supermajority dissolved because Senator Kennedy passed away, and in order to keep a majority, they had to get rid of the public option to get Senator Lieberman to vote in favor of it. Then went back to the House, of course, but by that time, the midterm elections had occurred, and it narrowly passed, just on party lines, 219 to 212. It was a squeaker. That was about the only thing that could be done to get a Health Care Act passed at the time. But then came the Supreme Court. Last slide, Emily. There are some realities post-SCOTUS that shows that the mandate was upheld, the Medicaid expansion was not. And so the coalition is now quite different. It's starting to fall apart. And therein, perhaps, is some room for action and for organizing. The Medicaid expansion was declared optional, which in some parts of the country, this part of the country included, could account for as much as 50% of access. So a lot of consumers are not going to get expanded access to health care. Rural and municipal hospitals who have high uninsured rates aren't going to be helped. Small employers, those who are mandated to provide insurance, those from the 50 to 100 group, often find they cannot afford to provide private insurance and often are having to bail out, in fact, threatening to pay the fine, give their employees what they can, and give them best wishes to shop on the marketplace. Specialty physicians have increased regulation and scrutiny. There's continued reliance on private insurance, and the undocumented are not included in the health care benefits. I'll stop. I just wanted to lay that groundwork. I think there's a lot of room for discussion. I've learned a lot thinking about these things and wanted to share them with you.
Good morning. I'm Art Sutherland, and since it's a Sunday, I thought we ought to preach a little bit and start out where we left off yesterday. That is, health care is a human right, and it is a social justice issue. Now, it's pretty vital to determine or consider how the social determinants of health affect health care. These are social determinants like education, economic stability, transportation access. All these things determine how people can access health care. If people can't access effective prevention and wellness efforts, this causes chronic disease and further illness. And this is basically creates the healthcare inequities that we see in our population in general. And then if you consider that people get in trouble with these chronic diseases, and then they don't have, they're faced with user charges, in other words, deductibles and co-pays when they try to see a physician or any other healthcare provider, they really can't get access to the healthcare system that they need. This explains why overall population health in the United States is poor, because we just don't have equal access to care and the right attitude for gaining care. Now, if the Patient Protection Affordable Care Act fails to cover everyone or control costs in our supply-driven markets, because it continues to ration access to medical care through the private insurers. Now, many will not be able to afford insurance, even with the subsidies, and everyone will be underinsured if you consider that all these plans actuarially are not 100%. So it's just a question of how much are you going to pay if you get some type of insurance. And then think about the fact that the Patient Protection Affordable Care Act failed to cover everyone on the national level, and the states have failed to expand Medicaid. All of this was done in the sort of name of budgetary constraints. Therefore, we fail to recognize that budgets are moral documents. And that needs to be honed in when you're talking to legislatures and people that you're trying to convince about this. There are a couple of attitudes that float around Congress. One is often spouted out by my Congressman, Steve Cohen, from the 9th District of Tennessee. He likes to say that politics is the art of doing what is possible. And to me, that's sort of a cop-out. But it's, compromise has been traditional since the start of our republic, often to disastrous results. But this theory that compromise is the only way to run the government, I can't accept. Now, contrary to that, there is some hope in Congress. John Yarmouth, who's a 3rd District Congressman from Kentucky, had a quote that says, "Government is how we work out our responsibilities to each other." And he's talking about the common good and what Congress should be thinking about. So keep those two quotes in mind, and let's see what we can do about it. The conclusion is that, as you know, only a single-payer national health program can solve our inequity problems and lead the nation both to improve personal health and to population health. Thank you.
start with the first slide there, Emily. United States has the greatest inequality of any country. This is from the Equality Trust, from work by Richard Wilkinson and Kate Pickett in London. And on the left, on the y-axis, you see an index of social and health problems. They put them. We have life expectancy. Let me point. Okay. Health and social problems. Keep this from falling, but I need to have it where I can read it. Health and social problems are worse in more unequal countries. That's the thesis of this book, and I have a copy here that I'd be glad for people to see. The spirit level. Let me just hold this one.
They also have a website.
No. That's okay. No. I think that's a recipe for disaster. How about just holding this and I'll hold that so you can see that. I'm sorry, folks.
It works.
So, life expectancy, math and literacy, infant mortality, homicides, imprisonment, teenage births, trust, obesity, mental illness, and drug and alcohol addiction, social mobility. So this is an index of health and social problems from better to worse, and this is income inequality from the lowest income inequality up to the highest. And here we are. If you can't quite make that out, here's USA. We're off the chart. So that's what's going on in this country. Next. Now, they didn't believe the results. So they came to the United States and they did the same study in all of the states. And this is a graph that shows the same health index of health and same index of health and social problems, comparing all of the states on levels of income inequality in the states. And you see the exact same result. Next. And this was an interesting observation. Trust. Do I trust you? When David tells me something, do I believe him? Levels of trust are higher in more equal United States, in more equal American states. All the way from fairly high levels, and these are basically New England states, and these are typically in the southern states. And Tennessee and Kentucky line up right in this area. Next. So this is the point. The rich, developed societies have reached a turning point in human history. Politics should now be about the quality of social relations and how we can develop harmonious and sustainable societies. Next, please. So, a different way to look at what the Reverend Dr. King said. Of all the forms of inequality, injustice in health is the most shocking and inhumane. So my thesis, and we can turn the slides off, is that a national, publicly financed, single-payer health plan would be the best thing that could happen in this country. In one fell swoop, on at least one level, health, everyone becomes the same. We not only improve the nation's health status, we seriously commit ourselves to the notion of a democracy with liberty and justice for all. So, what exactly is single payer? What is single payer? The physician's proposal for a national health plan I read in my office chair in August of 2003 when it was published in JAMA. And that's what got me here. And we have some copies of it. That and House Resolution 676 are the roadmaps to single payer. This is where we learn, we understand what single payer is. The message is that single payer replaces the health insurance industry and substitutes cost-efficient central planning for market-based healthcare profiteering. The term single payer means that one fund administered by a nonprofit government agency accountable to the public would make payment for all medical services, period. Is single payer politically feasible? Yes, it is. When asked if they would support, quote, a universal health insurance program in which everyone is covered under a program like Medicare, run by the government and financed by taxpayers, 2/3 of Americans say they would. Tell me a politician that wouldn't be thrilled to have that level of approval. That's political feasibility. In 2007, 5,000 physicians randomly selected from the AMA master file were asked, in principle, do you support or oppose government legislation to establish national health insurance? 59% said yes. 83% in some specialties said yes. Why the disconnect between popular opinion and congressional voting? Corporate power and campaign financing. Hold your hand up, Margaret. We must shine a spotlight on profiteering in a medical industrial complex. Single payer is politically feasible. It has been blocked by medical profiteers. Is single payer financially feasible? Yes. Professor Gerald Friedman recently showed on Medicare's birthday in Washington that in 2014 the U.S. could save an estimated $592 billion. 476 billion from the health insurance companies, getting rid of them, that is, and reducing pharmaceutical prices to European levels, which, you know, we pay 40% more, 116 billion. The savings would be enough to provide 44 million uninsured, complete comprehensive health care and upgrade for everyone else. No other plan can achieve this magnitude of savings. So what do we do now? We advocate and educate for single payers so that when the ACA crumbles, people will understand there is a solution. While the ACA has positive points, it is fatally flawed because of its inability to control costs and profiteering. Paradoxically, because of the ACA, single payer now has more and more recognition in the general public. We should take advantage of this inflection point in single payer awareness. As my dear friend and I do this every time, don't worry. I'm sorry. My dear friend David Boss, Reverend David Boss, said, keep your eye on the prize. Keep your eye on the prize. So Healthcare Now is the original single-payer coalition founded by Marilyn Clement from the Civil Rights Movement and Dr. Quentin Young of PNHP as the Campaign for a National Health Program, the original name. Importantly, one of the important leaders early on was an African-American pastor for peace. I'm going to repeat that. An African-American pastor for peace. We need African Americans. The church and the faith groups are critical to the life culture of African Americans. We'll never get there without all people of color involved in our movement. So now over 900 groups have endorsed House Resolution 676. I want to mention the One Payer States group, which is has a very informative listserv. Public Citizen, David, raise your hand. Thank you for your support. 300,000 Americans get information on single payer through Public Citizen. In addition to many statewide coalitions, there's a national coalition, the Leadership Conference for Guaranteed Health Care, which includes PNHP, Healthcare Now, California Nurses Association, Progressive Democrats of America, HATM, and All Unions Committee for Single Payer Health Care. Minority groups suffer the most from health inequities and disparities. These disparities are the worst in southern states. We particularly need to take the single payer message to them. This movement, as I said, will not succeed without the enthusiastic support of everyone, white, black, Latino, Asian. Now, would all students in this room please stand? I hope they have you recovered from last night. Now I'd like to ask everyone who is less than 40 years or less to also stand. Or if you don't want to really give your age, if you want to pretend you're in that age. All right, now let's give these people a hand. You are the future. Thank you.
We have time for questions?
We will. All right. All right, so don't worry, we'll definitely have some time for Q&A. But I am going to make you do a little bit of work first, so don't worry, it'll be fun. Thanks so much, you guys. That was really wonderful. And Dr. Adams in particular brought up several points of entry that we all, as single care activists, can use to organize in the midst of the ACA. Now, the majority of workshops at this conference are designed to flesh out these opportunities, and this, really awesome-looking guide that Healthcare Now has put together, it's in the draft form, is really all about this. And as the fellows and I from PNHP were planning this plenary, it became immediately clear that while we at PNHP are really good at some things, we're really not so great at other things. And in fact, we all work in solidarity, right? We need each other. I know there are dozens of different organizations that are present here today, and so there are a whole bunch of yellow sheets on your tables, which are basically a blank version of the exercise that I did in Chicago before I came here, that I would like you to spend just about 5 or 6 minutes doing, which is identifying either as in your organization or as an individual. You can do just one or the other, we probably won't have time for both. But spend about 5 minutes going through and identifying the things that you bring to the table for single payer organizing. So what are your skills, strengths, and resources that you bring with you today? We're great at research at PNHP. It's a really great visual impact to have a whole bunch of white coats present at a rally. But then also, what is the application of those assets that you have for this struggle in particular? And what can you bring to your coalition partners? And at the bottom, I'd like you to try and identify skills and resources that you have or your organization has that aren't currently really being utilized, that could be. And then what are the things that you need from your coalition partners? This will get us ready for these workshops that we're doing for the rest of the day. We should think strategically about how we can partner together. So you feel free to work in small groups if you like for a few minutes, then we'll come together and we'll have some time for Q&A. Thanks.